though they have so decided, we are not.
But a regent and a regional chief, they have come to the end of the road where they must accept the decision and move on.
Past were going to T or not, because referendum has clearly made it that we are part of OT. In fact, we are appealing to them to let matter go so that we embrace the district, the new district. The one is taken from the till that time, I am saying that we have no the one a newly created
Committee and the chief of Central Kofi, Nana Kofi Olato, the delay in properly constituting the new Guan district must be the concern and nothing more. With LI 2416 as Guam district with its capital as the although the changes were not entirely accepted by all, parliamentary election has had an open.
The rainstorm has affected teaching and
good morning.
Good morning.
Good morning, sir. How are you?
I'm very well, thank you.
Great. Great.
Aspen Dental, today is the day to take back your smile. Why wait? Save 20% on your
Good morning.
Hello, good afternoon, everybody. How are you?
Good afternoon. Yes. How are you?
Oh, is that? I'm all right, thank you. Mr. Kosa, how are you?
I'm very well, thank you.
Good, good. Glad to see all of you there.
And how are you?
Oh, well, I think that the sun is on and we're enjoying the sunshine in London today.
No cause to complain.
At all, not at all, not a chance.
And you've been left out a little bit, so you know.
Yeah.
You've stayed indoors too long, so it's good.
That's correct, and it's we are coming out gradually. So
yeah.
But the first thing I'm going to do is to run to Accra to spend some weeks there.
Yes, the hometown.
Yeah.
The old hometown, man.
Oh, definitely. I want to just come and enjoy the atmosphere.
Sure.
Perhaps get some nice plantain fufu to enjoy.
Hello, hello, hello.
Oh, good morning.
Hello, hello. Good
Morning.
afternoon.
How
Good
are you?
afternoon.
Just one office cannot suffice. And then we need to open our tentacles.
The municipal chief executive of Kasamanso, Solomon Afia, assures he has said with cooperation to ensure all punitive measures are given to corporate farm skills.
So, Brother Dan, how are you doing?
Oh, fine, thank you. How are you?
I'm good. I'm good. Yeah.
Yeah. Dr. Kosa was on earlier.
Oh, was he? Oh,
Yeah.
okay.
I think he stepped away for a little bit.
Okay. And Kwame Okulu.
Yeah, that's right.
Where are you?
I'm in London.
You're in London?
Yeah.
Okay. All right.
I know you're in Canada, isn't it?
Yes, yes.
Good. Yeah, I was in Canada in 1987.
Okay, that's why your name rings a bell. I was here.
Yeah, I was attending some international conference in Canada.
I see.
For a week or so.
Okay.
Mm.
Well, good to see you here.
All of you as well. All of you. I have been struggling with some very bad lower back for some days. Weeks.
Well, you're not alone. I'm actually in the same boat.
Oh goodness me!
Yeah,
It's
the
a very
past week
it's
has
a
been
very
a struggle
painful thing.
too. Yeah.
It's a very painful thing.
Mhm.
Mm.
Yeah. You have to contend with strong painkillers and.
Oh, I wouldn't go to that. I wouldn't take that route.
Well, I could not, I couldn't
Yeah,
survive without
I
it, but
know.
I don't stay on it for long. As soon as I
Good.
get some relief, I come off.
Glad
Yeah.
to hear that.
Yeah. No, my daughter is an naturopathic doctor,
Okay.
so she's not very much in favor of me
Yeah.
taking
Painkillers.
on she understands that yes, you combine the two, but as much as possible you stay with natural courses. So I don't typically resort to that as the first stage, but you get
Glad
to
to
a
know.
point where there's no choice. You
Yeah.
have to do something else.
Mm, mm.
I actually used to have acupuncture,
Yeah.
but with these days of
Yeah.
lockdown,
COVID. Yeah.
you can't do a whole
Yeah.
lot.
Did it work?
Physio, no. Anyway.
Did the acupuncture work?
Yeah, it does.
Yeah, it worked to
It
a
does
point.
help. Yeah. It
Yeah.
does.
Yeah.
It does. I used to have that as well.
Yeah.
Mm.
Hello. Oh, Dr. Binka's on. Good, good, good.
I've seen Nick too is also joining.
Yes, Nicholas. Yeah, he's on mute, and so
Okay.
I'm hoping he can hear.
Yes, I can hear. Good afternoon.
Good afternoon.
Okay, good
Nick,
afternoon.
are you still in London or you've gone back?
No, I'm still in London.
Oh, good. So the two of us are going to fly back together then.
When are you going back?
Just briefly to touch base around June, July.
No. I'll meet you at Accra Airport.
Oh. Okay, that's fine. Bring a big car to pick me up.
Okay.
Ladies and gentlemen, we present to you Showmaster of Africa, Bob Kilodos.
Yeah! I got a little story to tell you guys. Listen, I was one day walking through Stuttgart in West Germany when a friend of mine called me, Bobby! See that little chick coming with guitar shape. Wow! What a beautiful shape.
m'appelle Cyril Ortega. Bienvenue chez moi ici à Los Angeles. Écoute, si tu...
Hello.
Hello, good morning,
Hello.
everyone.
Good
morning.
morning.
So long you left me alone at home. Come back, love, and comfort me. Come back,
Hello,
love,
Marie.
come back home. Come back, love, oh love, come back, love. I need you, darling, come back home. I miss you, darling, come back, love. Come back, love. Oh, love, come back home. Come back, love. Oh, love, come back, love. I need you, darling. Come back, love. I miss you, darling. Come back, love. Darling, maybe you don't know how I love you. You are my one desire. Sweetheart, why have you taken this little talk so serious? Forgive me if I've offended you. Offenses are easily pardoned. Well, there is love. Remember the beginning of our love. All that you promised. And let's shift out if you really love me. If you leave me, I beg my bottom dollar. That's the end of me. So come back love and comfort me. Come back, love. Oh, love, come back home. I need you. Darling, come back home. I miss you. Darling, come back, love. Oh, why you leaving me in sorrow? Come back, love. Come back, love. Oh, Lord, you leave me. I will go right next. Come back, love. And comfort me. Come back, love. Oh, love, come back home. Come back, love. Oh, love, come back home. I miss you. Darling, come back home. I need you. Darling, come back home. Come back, love. foot. Oh, now I know we must fight for our own. We must fight for our rights. Success is all won by fight. So fight for it. Oh, Africa, my motherland, to be free now, we must unite. No greatness is achieved without pains and labor. As far as Rome was not built in a day, fight Africa, fight forward, forward ever, backwards never. Success is all won by fight, divide. One nation, one people, one destiny is what we need. Africa, Africa, Africa.
Good morning.
Hello.
Or good afternoon, depending on where you are.
Free now. We must unite.
Fred, good afternoon.
Hello? Yeah, good afternoon, Study.
How are you?
Fine, and you?
Great. Thanks for joining us today.
Right, thank you.
Privileged to have you here.
I understand Professor Acosta was on as well, but looks like he stepped away for a bit.
Okay. So what was the plan? Was he going first or was
No, Dr. Bink
going first?
Yeah.
Okay. And if that's the case, in the interest of time, we may want to get rolling right away.
Yes.
Yes.
You have to give me a co-host to be able to share my screen.
Okay.
You should be able to share it. You should
be.
have share content. It's set up for you to share.
Yeah, you should be ready. It should be set up for you to share.
Yeah. Okay.
Professor Acosta, good afternoon.
Adios, good afternoon.
Hello.
Yes, sir.
Charlie, how you doing? How you doing?
This was
your white beard be something on.
I tell you, it's a new look. This is what happens when you don't see your friends for a long time and you just send a text.
Yeah. Charlie, good show. You guys are doing.
Hi, Taddy. Good
morning.
morning.
Hey.
We're hearing some background noise.
Please, if you are not talking, mute your mic. We are hearing all kinds of sounds in the background. Everybody. If you are not speaking, mute your mic. Thank you. So let's get rolling since our speakers are both here. I'm Thaddeus Olsen. I'm the chairperson of PAG. We've been running a number of policy series for the last year or so. This is our 12th one, and this one happens to be on healthcare. And we are very, very fortunate to have two very accomplished experts in the area of healthcare in Ghana. I think these two brains combined will knock any other 2 or 10 people out. So we are very, very privileged to have them. On a personal note, Professor Binka and I are classmates. Professor Akosa and I go way back from GSTS when we were in sixth form together. And of course, he was my noisy next door neighbor at the medical school, but we'll leave that out. but we are very, very happy. I mean, this is a very serious, we are in a very serious state as a country. I think I do not need to belabor that. I know I hear of Professor Binka's frustrations every day on a platform that I am on with him, or a few platforms that I'm on with him. And but our PAG is really trying to create a good understanding of the problems that we have, so that right-thinking people can also come together and find solutions that are going to be useful. I know we all think we are still 18 or 20 years old, but we have grown old, as you can see by my beard and Akosa's hair, Binka's bald head. So I will hand over to our moderator, Phyllis Bourne, and we'll get started. Thank you all very much for joining today.
All right.
Thank you so much. So I will once again welcome everybody. Good morning, good afternoon, and good evening, wherever you're coming from. As you just heard, my name is Phyllis Dadson Bourne, and I am coming to you from Canada, Ottawa, Canada. Today, as you've heard from Dr. Thad Olson, we are going to be discussing the topic on healthcare. Does Ghana's healthcare system serve the people? We have here Dr. Fred Binka and Dr. Akosa, Ajiman Akosa, who are going to both give us a presentation and give us some insight into the system in Ghana. We're going to start with Dr. Binka. And just before we start, I'd like to please ask everybody to mute if you're not speaking, so we don't disturb the presentation with background noise. Also, we are going to go with the presentations first. And if you have questions, please put your questions either in the chat box or raise your hand, and they will be queued. And we will then go into a question and answer and discussion, open up for discussion right at the end. So without further ado, I will start the introduction with Dr. Binka so that he can give his presentation. So Professor Fred Binka, MD, is a Foundation Vice Chancellor of the University of Health and Allied Sciences, Ho, Ghana, established March 2012. He previously was the Dean of the School of Public Health at the University of Ghana. He graduated from University of Ghana Medical School, the Hebrew University in Jerusalem, and the University of Basel in Switzerland. He worked with the Ministry of Health for over 20 years. He conducted several large-scale community intervention studies to assess their impact on child mortality, vitamin A supplementation in young children, a community trial of insecticide treatment bed nets, meningitis vaccine and rotavirus vaccine trials. Finally, a health system-based trial to assess the impact of improved community access to primary health care. These studies contributed towards global and national policy for vitamin A supplementation, use of insecticide-treated bed nets, rotavirus and meningitis vaccinations in Ghana. Dr. Binka and his colleagues are the architects of national strategy of deploying nurses to rural locations to improve access to healthcare, health education and promotion, known as community-based planning and services. He has over 180 publications in peer-reviewed journals and chapter chapters in books. Thank you so much. And I will hand it over to you, Dr. Binka. Please go ahead. Dr. Binka, go ahead, please. Is he
I
muted?
think he's muted.
Can you hear me?
Somebody check there. He's muted.
Can you hear me?
Yes.
Okay. So I thank you very much for those kind words. I was trying to share my screen, but I can't find my presentation again. I don't know what happened.
Oh.
Yeah, can you see my screen now?
No, we can't.
Can you see my screen?
No, there should be a green button for share content. If you click that, then you can select the screen you want.
Okay.
Is the screen open?
Yeah, the screen is open. Let's hold on a bit. I don't know what's happening. Okay, share screen.
There, good.
You can see my screen now?
Great, yes, we see it.
Okay, sorry for the technology problem that we always face in this part of the world. So thank you very much, Phyllis, for your contacts and prodding me on. I think at one point I almost fell out of the discussion, but you kept coming back, and I'm happy I'm here today. Tadia and others, thank you for inviting me. I'm going to give a hopefully short presentation, and I actually will be learning so much from the interactions from this. And I have my co-presenter, the formidable Professor Kosa, doing the second leg. I'm happy I'm doing the first leg, so he can sweat it out in the second leg. Yeah. And sometimes it's a little bit of a challenge in this last year or so trying to use this technology. So what I do is that I give you my conclusions first. So if something happened, at least you know what my conclusions are. And my conclusions are: no, the healthcare system is not serving the people effectively. You are all aware that the leadership hardly uses the system. The middle class are at the private clinics that are springing up all over the cities. And the rural folks are suffering under non-payment of bills by the National Health Insurance Scheme that is supposed to deal with their financial support. The development of the healthcare system has continued from the PHC era, but got stalled under the influence of bad politics. If we go through the history, you will see that after we declared to get into the primary healthcare system in 1979, very much has changed, except the addition of the National Health Insurance and a couple of midterm strategies that were adopted by the ministry. Secondly, thirdly, I think we can develop an excellent system that addresses our needs. We are endowed with good human resources, experts, and the system that we have systems that have worked, like the EPI system has been fantastic in the last 30 years, and we are among the top in Africa. It's just that we are not working hard enough to get this done. And final by 2 points, the other problem we have is that we should stop the policy of any politician can run. Whoa. Sorry. We should stop the policy of any politician can run the health services. And so we've had a torrent of guys who have come to be in charge. And once you don't have a good leader, it is so difficult to be able to create reforms and to build on the system. Unfortunately, this is only happening to the health system. I have not seen a medical doctor being head of the judiciary, attorney general, minister for justice. And I wish they could make me the minister for finance. But that will not happen because I don't have the credentials to do that. On a very positive note, there is hope for the future because change is constant. There will be change in leadership, and we hope that one day we will strike it well. So PAG, work hard, and I hope we'll get there. So those are my conclusions. Now let's go back to the historical situation that we find with the health system in Ghana. At independence, Ghana inherited a colonial health system that was characterized by centralized control, principles of cost sharing, and predominantly curative care. And this was largely in the urban areas. When Nkrumah took over, he set a health agenda in which the country's achievements will be measured by the health of the people. So that was a different front from the colonial approach. The government developed a 10-year plan to drive its social and economic and health component of the plan involved expanding existing health facilities, reducing user fees, and in some cases adopting free care and to abolish private practice. This continued till Nkrumah left. The governments that came in between did very little on health policy-wise, even to restructure the system. This continued till in 1979 is the other landmark development within our healthcare system when Ghana embraced a primary healthcare strategy to achieve health for all by the year 2000. But the economic turmoil of the 80s made this health goal unachievable. And I think we all are aware of this. This was very common in most developing countries. One major component of that was in 1987, in order to deal with the issues of drug policies, we started the Bamako Initiative that involved subsidized drugs, sale to rural communities, and upgrading of basic healthcare systems by the communities from community savings. It is also in line with the 1979 Health for All by the primary healthcare system that we developed, the 3-tier system that I will talk about, the district, the sub-district, and then the community level. There are other landmark issues that I need to, wow, what's happening? It's frozen. Yeah, so there are other historical landmarks that we need to mention, but they didn't actually change the structure that much. There were additions to the system, and that's what we expect to happen, that we have several additions to the system. In 1996, the PNDC had a Vision 2020 that they established, and among it, one of its strategies was to improve health for all of Ghanaians, the health status of all Ghanaians, by increasing rural healthcare access. So that was clear that healthcare access in the rural areas was a major problem. And in 1997 to 2001 was the first medium-term health strategy that was developed. And it was also to increase access to care geographically and financially. And then the landmark replacement of out-of-pocket fees, which we used to call cash and carry, by the National Health Insurance System. That is still struggling today. It's limping, but it's there. It's working. So at the end of this short historical approach, we have the categories of healthcare delivery in Ghana are 4 main categories. We have the public not-for-profit, and this group are mainly the SHAG, the mission hospitals and so on, are private but not for profit. Then we have private for profit, and we have the traditional system that also provides healthcare. The public and the private not-for-profit are well integrated. In fact, in most places, the public assigns the private not-for-profit hospitals as designated district hospitals for people in those communities. It posts health workers there, nurses, doctors, and so on. And I think it does also provide resources, including supplies for the work of those district hospitals. However, the other two, the private for-profit and traditional, are still on their own, on a limb. They are out of the loop, and something could be done to improve on their place within the healthcare system. So now let's look at the structure. I'm sure you can read this. I also couldn't read it. This is the structure, organizational structure of the Ministry of Health.
Wow. Okay.
So this tells you, I mean, this, you can go to the website, you'll find it. This tells you how we are organized to be able to achieve anything at all. Just this cartoon alone tells you that there is a real danger as to what goes on there. There is a box on the right-hand corner. It's called agencies. And in fact, that box contains almost all of Ghana. And this box, the other side of the cartoon is just the people who support the minister. So we have the Ghana Health Service, the teaching hospitals, the private for-profit, the regulatory bodies, their links with universities, name it. Everybody is in this top right-hand corner box, and we all report to the minister. One minister, not even to the deputy. Everybody reports to the minister. And then you have all these other groups that are there, Director of Policy Planning, Technical Coordination, name it, all across there who report to the Chief Director. And then you have the internal audit and so on. And the minister has an advisory body and has deputy ministers. I think in the last 4 years, we had 2 deputy ministers that were assigned to the Ministry of Health. Then the big bullets here, unfortunately, because they are in that box, it's also difficult for you to see what exactly, how to break it down. But I will show you how the structures of the other groups are. And the key ones are, let's say, the teaching hospitals. So the teaching hospitals are also structured in this way, where they have a medical director, director of nursing, administration, finance, and so on. And they are at par with the Ghana Health Service, which I'm going to focus on, because they do the bulk of the activities. Today, we have, I think, 5 teaching hospitals in Tamale, Kumasi, Accra, Cape Coast, and Ho. Then you have the Ghana Health Service. This is the cartoon of the Ghana Health Service. Also, really difficult to see how these things work. So you can see the weight that I put on everybody. You have the national in the blue box here, which has the technical directors. But let me draw your attention to the wine-colored box here, which is RDS, that today has 16 people in that box. 16 regional directors are in that box. And the violet box here, which has district directors of health services. At the moment, there are 275 districts. So there are 275 people in that box also. So this is how this is established. This is how it works. And obviously, as we say, you have to create the structure to deliver your functions. And from here alone, this re-emphasizes my no vote on all these things. Now, I put in this chart slide to show you one of the most important covariates that we have to look at in education and provision of education, and that is education. And still, we are not in the clear at all. The number of people who are still not educated has changed dramatically from 1998. We're having about 39.7% of the female population not educated. Today, we are down to about 19%, I think. So we've made some progress over time. And this level of education also is important to look at what happens when we provide a service to the people, because health services are generally supported by people, not just the treatment of illness and straightening of limbs and so on. So I put this here, but let's go back to the major issue of the structure and how the structure has delivered. Let's look at the human resources. We've done very well over time. We started very nicely, but as we speak of the data that is available on the reports, indicates that we're still not so doing very well. Nationally, by 2016, we had 1 doctor to over 8,500 people. And obviously, this varies considerably from almighty Greater Accra and Ashanti to Upper West and Upper East, where it's like a no-go area for doctors. So in 2016, Greater Accra is doing very well. 1 doctor to 3,582 people. And Ashanti is doing 1,000, 1 doctor to 7,848 people, still above the average. But then we have Upper East about 25,000 and Upper West about 18,000. It's not different from the other health workers, but let's pay attention to this one, which has to do with nurses. And in the nurses category, the interesting thing is that the auxiliary nurses have actually carried the system to where it is today. Certified general nurses are very few. If you add the midwives to the general nurses, you're about only 20,000 nurses in total. That was in 2016. And the auxiliary nurses are quite a lot. About 32,000 of them are auxiliary nurses. And in particular, the first box that shows community health nurses is critical because they have been playing a very good part so far. Those are about 15,000 of those community health nurses available, and they will feature very prominently in what I need to talk to you about. Look at pharmacists. There are only 619 pharmacists as at 2016 in the services. So we still have a lot to do, and we still have many more health workers to play their roles in providing care. Now let's look at the facilities. This is one of the interesting parts of this whole system. So as we developed the system from expanding facilities from the colonial era through the Nkrumah era up to the 4th Republican status, we have in total 6,815 facilities. I'm sure the number has changed so far, but not too much. Among these 6,815 facilities, we have about 267 hospitals and 855 health centers. And then we have maternity homes and so on. The figure you need to be paying attention to is the first box, the CHIPS compounds. I will talk a little bit about them later. You see that the CHIPS compounds are about 4,185, forming about 61% of the health facilities. These are 1 nurse or 2 nurse stations that are scattered across the country. And even that, the density is not what we expect. So if you are planning to increase your facilities, it's obvious that the way to go is to look at the CHIPS compounds. Recently, the president announced building 111 hospitals coming out of the pandemic, virtually not discussed, not informed. It's not going to do anything. It's not going to change the landscape. There are only 267. Adding another 100 will not make any difference at all. So some of these things need to be discussed as we develop and build the system. So those are facilities. Now let's look at the products, outputs. Infant mortality is one of the main indicators that we tend to use to look at what is happening around the world. And at the moment, we are not doing badly. By 1988, we are around 77 per 1,000 live births. Today, we are around 41 in the last indication in 2014. So have there been a steady drop in all mortality indicators over the time, including, strangely, fertility has also done well. We are having less children per woman, 6.4 in 1988, and in 2014 we're down to 4.2. We need to get further down, otherwise the population rate is going to go up. Life expectancy, yeah, we were doing well, but I think somewhere along the line, the trouble started with HIV/AIDS and so on. So we are from 54, and in 2014 we had 62. Now let's look at the outpatients. So if you look at outpatients, in 2016, That's the latest data that I have. In fact, we are doing 1 visit per capita as far as outpatient visits are in some of the data that I've seen. But malaria, upper respiratory tract infections, rheumatism and other joint pains, diarrhea, skin diseases, intestinal worms, acute urinary tract infections, then comes hypertension and acute eye infections and typhoid fever are the major ones. I think by now in 2021, hypertension and cardiovascular disease will be climbing this list, but they are not yet at the top. It's still malaria, which is still reigning at the top, and we have to do something about that. And this has been, and there's been no real change between 2002 and 2016. We've had ups and downs, but the important thing is that we're keeping the data, and hopefully the data is correct and we have all the data. But I have just checked clearly, and I've been told that this data is from the DIMS, but the teaching hospitals have not been contributing their data to the DIMS. What a shock. Anyway, from the morbidity from sickness, let's look at those who are dying. And we are looking at deaths that are reported nationally. And in 2016, we still had malaria as the main cause of death, pneumonia, asphyxia, HIV/AIDS, anemia, hypertension, and you see that cardiovascular accident is showing up at number 7, diabetes at number 8, and then septicemia and gastroenteritis. So this is the picture that we have. And this picture must inform the health service delivery that we need to provide to reduce both morbidity and mortality from these ailments. And so as we speak today, Ghana is still in the infectious disease box, but the non-infectious disease or the chronic diseases are also showing up, and our systems have to look at this very carefully. So going forward, I think there needs to be a reform. I'm sure every country will make a reform to its ministries of health after the pandemic, because most health systems have been challenged across the world. You don't even spare almighty America. And we are not yet thinking about that, strangely enough. It's a little bit sad. But I have recently written a paper trying to look at what I think should be the reform, and I'm going to present a little bit of that quickly for this discussion. I think the ministry should be reformed. You saw the first cartoon that was there was completely, you couldn't implement that and achieve any effectiveness in the services. So I think there must be 3 core functions that the ministry does. We have the administrative and allied health services, technical coordination, policy, regulatory, logistics, development, and functions should sit in one division. And then we should have a division of clinical health services that ranks from the tertiary institutions right to the chief's compound in the village. At the moment, they are split, and there is really no written links between them. If you were to look for a referral from Bogatanga Hospital to Kolebu, you must know a few people before you can arrive. Your ambulance can arrive at Kolebu and you will be going around in Accra trying to find a place. And thirdly, I think it is now time to create a division of public health and sanitation. And truly, without that, we are seriously in trouble. This was the key at the beginning, but the clinical service sort of consumed all of this. But without the division of public health and sanitation, interestingly, in Ghana, we created a new ministry, but we called it water and sanitation. And the reason why I decided to add the sanitation boldly is that, look, sanitation, galamsey, all these things are problems, but you achieve an increase in the mileage if you attach it to health. Health, everybody understands what health is. And if we are pushing people to keep their compounds clean so that they'll be healthy, we will go the extra mile rather than saying, okay, don't pour the thing into the gutter and so on and so forth, or don't put the mercury in the water and don't make it mad. So there should be a division of public health and sanitation And those are my 3 proposals. I will just briefly look at a few things within this, not too much, 2 or 3 slides. So my division of public health and sanitation will have a CDC, a Centers for Disease Control, which will look at both infectious and chronic diseases. It will look at research and training within the ministry, laboratory services, health promotion, public health services, and then we'll look at the health center. I will move the health center and the chief's compound into the public health and sanitation area. Then there will be a big development on sanitation, and then there will be a department on public health development. Then we have the clinical services, which will have the tertiary, regional, and district hospitals. We can do the details. This is what we've been doing all along, so I'm not going to spend time there. And then the division for administration will look at the administration, the agencies, regulatory bodies, and the wider health sector. Let me go to the next on the division of clinical services. I think when I look through the data and the information that is available, we are still back to 1997 when we adopted the primary healthcare. The policy document for 1997 is still relevant. It says, because most disease problems that cause the high rates of illness and deaths among Ghanaians are preventable or curable if diagnosed promptly by simple basic and primary healthcare procedures, the major objectives of the ministry are to extend coverage of basic and primary health services to most people possible during the next 10 years. And the next addition to that is that in order to provide this extent of coverage, it will be necessary to engage the cooperation and authorization of the people themselves at the community level. It's people who generate wealth, health. So that is very paramount. It will involve the virtual curtailment of the sophisticated hospital construction, renovation, and will require a reorientation and redeployment of at least some of the health personnel from hospital-based activities to community-oriented activities. And it's based on that we developed the National Primary Healthcare Structure, where we had a district hospital, we had health centers, and then we have the community level. Today, I'm proposing that the health centers and the community level are put together, because the chief system that is driving 60% of the health delivery system today in Ghana needs a health center to operate appropriately. It cannot work on its own. Sorry, I'll finish very soon. And these are the levels, and I hope that we can, if there are any questions about that. Now let's go to the public health and sanitation arm. I'm looking at infectious, chronic disease, laboratory research, and links with already existing. We have the West African CDC that is centered in Nigeria, and then we have the African Union CDC that has been very prominent in this last days that we've had the pandemic. So we could discuss that. All this will take days to look at the fine prints, but this is the concept. And then in sanitation, we push the primary healthcare system that people have to generate health. We look at the water resources and disposal of waste, but we should also have intersectoral collaboration with local government, the judiciary, energy, agri, and so on. This is what the chief system is. I'm sure if you're abroad, you may not have known what the chief system is. These are auxiliary nurses that are trained. They're given 2 years of training. Most of them left senior high school and didn't have as good grades as those who went to nursing school. So we trained them. This is the nursing training school in Avrongo, where we were instrumental in building this up. Today, there are 10, there are nursing training, community of nursing training schools in all the old 10 regions. And I'm sure they will spring up in the new regions that have been added. The compound down there is the chief's compound where the nurse lives. So instead of building a health center or a clinic, you build a place for the nurse to live, and he can run his clinic from his veranda. And then the important thing about the chief's concept is not becoming treatment of illness. The nurse has to have a catchment area, and he has to visit everybody once every 3 to 4 months. So the nurses always have a motorbike. I hope I put a few more pictures. Yes. So they have an essential equipment, is their motorbike. They can go around The community is part of the business. The community will construct the health center, will contract the chief's compound, and will work directly with the community. So the community health nurse in the top is seeing a child, but doesn't have to have a room with table and everything to see the child. In fact, when the community health nurse is going around, she carries a bag at the back of her bag, which has all her drugs and basic equipment, and can see any child when he visits the home. So that's another concept, but this is the way to go to reach as many people as possible in our country today. I've told you about the conclusion. So in conclusion, our current system is not effective. We need to do something about it. We need to continue the development process, and we need to stop being, we need to get serious and send strong leaders to go and revamp this health sector. Ghana can do better than it's doing now, and there's definitely hope for the future. Thank you to the audience and to the organizers. Thank you very much.
Thank you so much, Professor Binka. This has been a very, very insightful presentation. I know I've learned a lot, and I'm sure everybody else has as well. We did have it a little bit longer than intended, but I think it was well worth it. So without further ado, I will go straight to Professor Akosa's presentation. I will proceed to introduce him so that he can go ahead. Okay, can we take the slides off?
On sharing screen.
So I'm coming, I'm going to learn it again.
Okay. Whilst you're doing that, I will introduce Professor Agyeman Akosa. Okay.
Where are you?
Professor Agyeman Akosa, MD, is
if
a
you go up, stop sharing.
Pardon?
Please.
Okay. Yeah. Okay.
Yeah. Please. Can I add a voice?
We are going to take.
No, I would like to ask that the data given here, I've already sent in a chat.
Yes, I've seen that, but as we said, we will be getting to the questions at the end.
Not a question though. I just want to ask.
I know. I've seen your chat. I have.
Very good.
We will attend to it at the end. We just want to give Professor Akosa a chance to do his presentation, and then we will deal with everything at the end. Sorry, I meant to say that.
Thank you so much. Thank you very much.
All right, thank you. So Professor Agyeman Akosa, MD, is a graduate of the University of Ghana Medical School, 1979, and became a fellow of the Royal College of Pathologists. He is also a fellow of the West African College of Physicians and a foundation fellow of the Ghana College of Physicians. Dr. Akosa was consultant histopathologist to Forest Healthcare Trust in the UK from 1990 to 1995. He was professor and head of pathology of the University of Ghana Medical School from 1997 to 2002, and then Director General of the Ghana Health Services from 2002 to 2007. He currently works as a private consultant, cellular pathologist in Accra, Ghana.
Come in.
Dr. Akosa is interested in a seamless healthcare. Please mute if you're not speaking. Hello. Please mute your mic. Okay, sorry about that. Dr. Akosa is interested in a seamless healthcare delivery system in Ghana, where the very best services are provided to all citizens, irrespective of social status, religion, or ethnicity. Dr. Akosa provides us more insight into the policies, structures, and functions. Please go ahead, Dr. Akosa.
Thank you very much. Let me say good morning, good afternoon, and good evening to the audience. And let me say how happy I am that Fred took the first bait, because he has really exhausted the topic. And what I'm going to do is just try and weave through some of the issues and probably just reinforce the message that Fred Binka put out. And I think that I'm not doing a formal presentation, but I would like to say that I think the conclusions are very clear. I mean, the health care delivery system as we have it now is certainly not serving the people. It's not serving the people because, again, if anybody was giving a blank sheet of paper to devise a healthcare system, I don't think that what we have today is what anybody will come out with. And I think Fred clearly showed that if the CHIPS concept is doing 61% of healthcare delivery now, then that should be the focus primarily. And the focus should be such that no Ghanaian should be more than 5 miles from a facility. Certainly, as you go further out, you realize that the services do not serve the people as well. And therefore, the number of CHIP zones, as he has indicated in 2016, and I don't think it has expanded very much. The original concept was to have about 6,280 serving the entire Ghanaian community. So we are close to almost like 2/3 of what was anticipated. We still have a long way to go, because the idea is that people should not be far away from a CHIP zone. And for me, even though Fred did not say it, the whole CHIPS concept came from his work in Navrongo. Of course, working as head of the Navrongo Research Center, realized that the more you put people closer to the community, the better their health outcomes. And this, even though started in a research center, was validated in a typical district in Nkwanta, and that is how come it became a policy. We've all realized that it is important. I always tell people that the beauty of the CHIP zone is that a child gets convulsion in a village, and the following morning, if there's a CHIP zone, the child is alive. If there is no CHIP zone, the community gets up and starts mourning the death of the child. If a farmer goes out to farm and gets a cutlass wound in an area with a CHIP zone, the cutlass wound will be cleaned, properly bandaged, appropriate drugs provided, and in no time, the farmer will be back to work. If there's no CHIP zone, the likelihood is that they would probably even apply cow dung to the cut. And in about a week's time, you have a patient with tetanus. And you then have to take this patient, through all the difficulties of transporting a patient from the periphery to a district hospital. And this patient will be hospitalized for a very long time and go through the challenges of having tetanus. So it is almost like day and night having a CHIPS compound. Originally, the concept was to have one person there, but we've all realized that when I was Director General, there were opportunities for me. I visited many CHIP zones, and there was nothing worse than leaving your nurse in a community, pitch darkness, at 12 midnight, knowing that 365 days in a year, she is alone in a CHIP compound there. Unfortunately, there are bad people around, and some bad people take advantage of the CHIP compound. There were cases where their bicycles get stolen, some of our nurses get molested. There was one instance where I had to close a CHIP zone because the motorbike was stolen. And in a community like this, people know the person who is stealing it. When I closed it, 1 week, they found the motorbike. We're lucky that in this instance, it hadn't crossed the border for parts to be, the motorcycle gets dismantled. So for me, if we had a blank sheet of paper devising a health service, the first thing is to make sure that every part of the country is served by a chip compound. That for me is the first premise. The second is that the CHIPS compounds must be supervised. And I think one of the things that Fred alluded to is community participation. I mean, in establishing a chip compound, there are several criteria. And one that I like is the fact that the community must accept that they want it. And the community must actively participate. In the original plan, there were supposed to be village volunteers who were given bicycles, who could come to the chip zone if there was any difficulty. I mean, in these days of mobile phones, and Ghana has such a mobile phone penetrability that, you know, just give them mobile phones, you know, what we call in Ghana YAM phones, the small phones that don't do anything other than the call. And, you know, people can be cared for properly. Then, of course, the next stage is the health centers that oversee about several chip zones, I mean, referred to as the sub-district. You know, the sub-district supervises the community. And in Ghana, one of the challenges is leadership and supervision. We almost believe that because we do not have enough doctors, we don't have enough healthcare professionals, we can, you know, virtually gradually give authority to different health professionals to oversee healthcare. But the problem is that we do not supervise. And oftentimes, people take the law into their own hands and begin to do things that they really do not have the professional ability to do. So if in this country, we're able to tidy the CHIPS compound and we're able to support it with the health centers that has a medical assistant or a physician assistant, that has a midwife, that has a few more nurses, then I would say that almost 80% of the healthcare delivery system of this country would have been tidied up. Then, of course, we come to the district hospital. But unfortunately, our system is such that the district hospitals now have become almost like the mainstay in the healthcare delivery. And no wonder the president is eager to build 111. And it goes without saying that putting up a hospital presents a greater opportunity for corruption than putting up a CHIPS compound. You know, the Ghana Health Service itself has a standard district hospital that should cost not more than $7 million. When I became Director General, there were 3 hospitals that were built, you know, shortly after the approvals had been given. The first one was Begro or Fantiakwa District Hospital. That hospital had been contracted at 15 million euro. No, the first one was Sugakope at 15 million euro. Twice, more than twice the Ghana Health Service, you know, specification of $7 million. The second one was Begro Fantiakwa at 18 million euro. Goes even higher. And the last one was Gushegu at 23 million euro. So, you know, it was almost as if there was Ghana Health Service with its own criteria, wanting to set up district hospitals, you know, and somehow the Austrian government provides support. And this was the first time when I met Alfred Wildme, who was then consul of the Austrian embassy. And these agreements had been made and signed by the Ministry of Health and Government. And these were built. Now, within the same day that Adan Hospital which was built by the Chinese at $4 million, was the day that it was commissioned, that same day Sogakope was commissioned. And the two district hospitals were like light and day, because most things that were not even necessary for a district hospital had been provided in Sogakope. And I must say that not necessarily at 15 million euro. And I remember President Kufuor asking me why I wasn't at the inauguration of Sogakope. And I told him then that I met the consul of the Austrian embassy. And I asked them that since Ghana Health Service had an upper limit of what a district hospital should cost, I really wanted to know value for money audit for Sogakope, Fantiakwa, and Gushegu. And he told me that approval has been granted already. So what I was asking for was certainly not necessary. And therefore, as Director General, I had no hand in it. And therefore, I didn't see why I should come to the inauguration. So he asked me what was the cost of it. And I told him 50 million euro. And he asked me, I was at Adan, so he asked me how much Adan cost. And I said, 4 million euro. And he said, 15 million euros and 4 million, and these are both district hospitals. But he said that, look, if at least 3 million had been spent extra on Adan, it would have made the hospital a perfect hospital. And that would have just brought the cost of Adan to the 7 million euro that Ghana Health Service had. So these are some of the things. We want to build things just so that we can create the opportunity to milk the system. All right? So this is one of the major challenges, that the health system as it is now certainly does not meet the needs of the people, because the system is built in such a way that preference is given to district hospitals. And of course, if you get to the district hospital, you having moved from wherever you are through the health center to the district hospital, there's no facility for carers to stay. And I know that if you go to any of our hospitals, we've created almost like a ghetto where people who bring patients to hospitals then have to live. Unfortunately, when I finished medical school, once you were admitted into hospital, the care was directly under health professionals. There was nothing like, carers coming in to give you a bath, come and feed you, etc., which now is the mainstay. And this all came as a result of the cash and carry era, where everything had to be paid for. Even though we have national health insurance, we certainly have not abolished cash and carry. And I must say that even now, cash and carry is so pronounced within our health facility. Not only that, before any doctor sees you, even in a public service, there always is some transaction. And again, professional ethics is being eroded seriously. So we live in a system where even though people come with national health insurance, somehow there is payment to the professionals and to the hospital facility. And I think Fred Binka spoke about the fact that the national health insurance takes its own time to reimburse hospitals, and hospitals must perform. And therefore, unfortunately, their reliance on cash and carry is still very, very clear. There is lack of leadership at all levels of our healthcare, all levels, clinical, public health, everywhere. There is lack of effective leadership and supervision. And I think these are some areas that they might appear the soft areas, but are so crucial. You must have leaders who are prepared, to give their all to the service that they lead, and not Director General stay in Accra and expect that, yes, your regional director is there, he's doing the work. And, the report you get is the report that you want to hear, so to speak. So it's important that leadership, team leaderships, teamwork and leadership should be incorporated into the training. Anybody who aspires to become a leader, of course, within the health service, must go through effective training. So that is equally important. Now, human resource. We may think we have enough, but at every level, we suffer from serious deficiencies. Unfortunately, 2 years ago, the Nurses and Midwives Council accepted a cut in production of nurses. And yet, if you go to every facility, there is a deficiency in the number of nurses. And what is happening is that the nurse auxiliaries that are being trained are now being made to do professional nurses' work. It's important that we continue to produce the human resource. Doctor-patient ratio is still very bad. Ghana at this level, even for poor countries, you're supposed to have 1 to 5,000. In a lower middle income country, you're supposed to have 1 to 1,500. And yet we're still hovering around 1 to 8,000. And somehow we don't think we need to train enough doctors. And most Ghanaians who qualify to do medicine now will find their way to every part of this world other than Ghana, go and train, and then come back. And of course, they have to come and do exams. And if you know the problems and challenges of people who know they have qualified as doctors elsewhere, who have come to Ghana and are unable to pass even the entry exam in this country, it creates a lot of problems. And I'm looking forward to the day when we would have enough medical schools to train enough doctors, enough nursing institutions to train enough nurses, and so on and so forth in all the professional groupings. Now, let me talk about medical devices.
Can I just interrupt to ask whoever is making the noise in the background to mute? Can everybody mute your phone, your screens, so that we don't get interruption? We just have a few minutes to go before we open up for discussion. So thank you.
I'll be quick. Let's talk about drugs and medical devices. That a country that has had polytechnics for so many years cannot even produce what I call a fetal monitor or a cardiac monitor. What is in it? We can't even produce electricity regulators. So that for all the electrical things that we import, within a short time, because of the poor stability of electricity, a lot of these electrical items get blown. And yet, for this country with so many polytechnics, we should by now be able to produce a lot of the miniature medical devices, even including ventilators. If you know the number of ICU beds that we have and the number of ventilators we have in this country, we were just lucky that this pandemic really passed us by. And I'll use the word passed us by because if it was anticipated, if we had the numbers that were anticipated, we would be in a sorry state. If you can imagine India that provides for Ghana most of its drugs, provides for Ghana most of its vaccines, provides for Ghana a lot of medical devices. Look at the state that India is in. So you can imagine what would have befallen us. But our ability to produce a lot of these things, is there. But somehow nobody wants to support the healthcare delivery in terms of our ability to provide some of these things. Vaccines, we don't. Why not? A small country like Cuba, that doesn't have a GDP like Ghana, is producing 13 vaccines, and we don't produce anything. Even drugs, generic drugs are imported into this country. Generic drugs that have gone past 10 years and therefore anybody can produce are imported into this country from a myriad of countries. And that is how you introduce fake drugs into the community. And I will tell you something that a study done by Professor Oforeje clearly indicated that 75% of drugs sold in off-the-counter pharmacies and pharmacies are fake. So you are even looking and supporting Ghanaians, and you are not certain whether at the end of the day, drugs that have been provided are useful enough. Of course, again, it was said that we collect data, and we have a very good system of collecting data. But unfortunately, I would say that so long as we do not have a unitary health system, The teaching hospitals think that they are a lord unto themselves. They would not even support and provide their data for, you know, the whole country's planning. You know, and I say this all the time. If you go to UK, London alone has 10 medical schools, but the 10 medical schools are not all independent entities of the National Health Service. So if London with 80 medical schools, you know, are all subsumed under the National Health Service, why should Ghana, and now that we're having increasing number of medical schools, we're going to create several teaching hospitals independent of the normal health system. And I like the example that Fred Binker gave, that if you're coming from Bolgatanga to Kolebu, you will meet several blocks in one country's health system. And I don't see who it benefits. And yet there are people who are fighting against a unitary health system. So of course, our system certainly doesn't meet the challenge. Unfortunately, again, one of the difficulties we have is that public health doctors are allowed to open their own practices. Somehow, I don't understand why even the private sector is not complaining about it. So people have worked in a government hospital and have their own private hospital. And you can tell me 24 hours within a day, how much of it do they spend in the public sector for which they are paid, and how much they spend in their own private sector. And we know that people have pushed patients from the public sector to the private sector. And people talk about even equipment moving from the public sector, you know, to the private sector. Somehow we are unable to control this. If you live in the UK, you cannot, as a doctor, have your own private practice. You can only engage in private practice as a consultant, and therefore you must get to the top level before you can even do private practice. And private practice is regulated. But in this country, as soon as you are even a house officer, that's private practice. And yet, probably 1 year, 2 years into medical training, medical practice is allowed to see patients privately. So we have a big issue, and we have got to tackle, number one, the leadership issue. We must tackle supervision in healthcare delivery, human resource inadequate, drugs provision inadequate. And again, if we don't produce them, we will never be able to tackle the issue of fake drugs in Ghana. And it's a huge problem. Fake drugs is a huge problem in this country. And finally, we've talked about data as well. And finally, it is community participation. Health is about the people. And the people everywhere should themselves be interested in the provision of good health care. And once you bring the community in, then of course, all the, you know, the social determinants of health comes in. And Fred talked about sanitation and education, but you can talk about everything that, you know, goes through to provide, you know, a healthy human being, are all important in healthcare. And I have always said that if health is put at the center of national development, that is when you see that it is indeed the health of the people is the wealth of the nation. And that, for me, you know, captures all. You may have all the natural resources, but if you have a healthy population, you aren't going too far. There's nothing that you can do with all your natural resources. So you need a healthy population, a healthy, educated population. But it starts with a healthy population. And once we have that, then I believe that that becomes the major ingredient of Ghana's takeoff in the future. Thank you very much.
Thank you so much, Dr. Akosa. And I actually want to extend thanks to Dr. Binker as well with everything that we've heard. This is a real eye-opener, I think, for myself and for a lot of you on the platform, I'm sure. We will now go ahead to the Q&A and open discussion and comments. I would like to ask Dr. Binka if your slides are going to be available to us to be able to share with those who are interested. We've had a question on that. Would that be possible?
I have sent you the slides by WhatsApp.
Okay, excellent.
Yeah, with you now. Yeah.
All right, perfect. Thank you so much. Okay, so I will have Dr. Asola. I believe you will be queuing the questions for me in the chat room. We have a few already there. We can call on those who have put questions on, or you can read them out if that works better.
Okay. There are no hands up yet on my screen.
But we do have some in the chat room already.
Okay. In the chat room now.
First question is, I think, from Mauli, Eli.
Okay.
The others are comments, but there's a question that says in the chat.
Yeah. Prof, if you see, okay, yeah, I see it now. There is one. Mauli says, please, you said the auxiliary nurses had carried the majority of the burden at the periphery of the health system. Is any data that supports the fact that physician assistants also carry the burden at the periphery? Is there any data?
Well, I could answer that. You know, every group will want to talk about what they are contributing, but I've just shown you the data that 61% of the health facilities that is on the list for the Ministry of Health is CHIPS compounds, and the CHIPS compounds are manned by the auxiliary nurses. So that's the data for you. I don't have data for the physician assistants carrying the data in the hospitals. Most of them are either in the health center or in the hospitals.
Okay. Second one talks about that there's a conspicuously missing is the data is the major role of the physician assistant. This layer of profession provides the imperative medical service to the rural community where the doctors have totally been neglected. I hope Dr. Agyemang-Akorsah touched on this. I'm sure he did, but if you want to revisit it, Professor Akorsah.
Let me say that, I mean, as far as the systems are concerned, the health centers are manned by physician assistants. And therefore, if you want to say that as far as the peripheral healthcare is concerned, the first referral point is the health center, where, you know, the leadership at the health center is physician assistants. They provide an essential service. Even in most districts, the district hospitals and the polyclinics, a lot of the service there is provided by physician assistants. So yes, you know, we must make a point that every category of health professionals do their work. And I think that the point that Professor Binka makes is that if 61% of healthcare delivery takes place at the CHIP zones, which are manned by auxiliary nurses, then there is no doubt that the bulk of healthcare delivery rests on the shoulders of auxiliary nurses. But that is not to say that all other health professionals don't do their bit. And therefore, we should not isolate one group and say that what is their contribution. Of course, each group is contributing. How many physician assistants do we have in Ghana? You know, physician assistants, if there are, let's say, 4,000 doctors, I would think that there should be 20,000 physician assistants. But how many physician assistants do we have in the country? Not that many, and the fact that they are in the health centers doesn't mean that they are carrying the entire healthcare delivery system in Ghana.
And I would add, Kofi, that it really speaks to your point about supervision. Many of these folks have some ability to provide healthcare, but very often people go outside their scope of practice and endanger people. So how these different professions are integrated and supervised is actually critical to the healthcare of the population. Yeah, because I see that when I come into work. I mean, just to give an example, it's a young guy brought in from Asinfosu to the Ankafo Psychiatric Hospital. They said he had a seizure. They thought it was malaria. Clearly, he had been seen by somebody. They assumed it was malaria. In the end, he was paralyzed. And clearly, it was meningitis. The diagnosis had been completely missed because nobody was supervising that individual there. And I also think that probably we need to be thinking about how to use technology more to supervise people in the periphery. Because sometimes the person simply has a question that a more sophisticated healthcare worker can answer for them for the benefit of the patient. So again, in our policies, the role of technology in providing supervision to the periphery is something we really have to think about.
Thank you. We have one more on the chat and then two hands up. I would read a question from Dr. Tampogre. Professor Kosa, what factors are responsible for the strong resistance to change in the health sector? And going forward, how can change be brought about? Of course, knowing fully well that the required political will and determination is a key determinant.
Well, I mean, let me say this, and I think, Prof. Binka did say that the health service was probably the only, I would say, the major ministry in this country that anybody is made a health minister, because somehow people feel that it doesn't matter, it doesn't need a health operative. And there are people who even say that if you make a doctor a health minister, it certainly doesn't work. Look, unfortunately, the cooperation between professional groupings in Ghana has been jolted by so many things. And we can go back to 1979, we know go sit down, that paralyzes proper leadership and so on and so forth, that everybody thinks that I am somebody, and therefore I don't need to be checked, I don't need to be supervised, and so on and so forth. And there are resistance between many of the professional groupings. The pharmacists and the doctors, for example, the doctors and the physician assistants, and there's so many that it takes proper leadership to address these issues. And that is why I say that team leadership, it's not even the single individual who is the medical superintendent that matters, but the fact that there's a team, and the team has the chief nursing officer, the chief pharmacist there, who, as a team working together to deliver health service in a particular district. And therefore, again, brings in supervision at the health centers and at the CHIP zones. So that is important. We need, look, in any developed system, all right, you do not have those kind of fracases between professional groupings. Everybody knows what they are supposed to do, and everybody knows who they report to, all right? So why is it different in Ghana? I mean, if you come into even some particular areas, it's worse, all right? I mean, for years, laboratory scientists and laboratory physicians are loggerheads. And if you ask any country where, this thing is happening, the only country they can refer to is Nigeria. And Nigeria, quite recently, their Supreme Court has passed a ruling that, the heads of laboratories must of necessity be laboratory physicians. Why should there be this fracas? And they are supported by politicians, because this is where in Ghana you create a problem. Once you've got a hearing from politicians, you can do whatever you like. So change would always come within the health service. Change must come within the health service. And if we were to draw a new health system, I would say that most definitely the emphasis will be on periphery towards the center rather than the center towards the periphery. And if we're able to change that dynamics, the outcome, and that is what is important, the health outcomes of the people of this country would improve tremendously. No doubt at all. No doubt about that.
Thank you so much. I think somebody is trying to hijack the screen. Could you please?
Yeah.
We'll have Kofi. Your hand is up, and after that we have Infinix Note 7. I don't know who you are. There's no name there, but let's have Kofi unmute your mic and ask your question. Thank you.
Okay, greetings to you, my elder sister in the chair. Greetings to my elder brothers who spoke before. My elder brother Binka and elder brother Akosa, whom I know personally. I'm Kofi, Africa to Nkrumah, participating in your forum for the first time, speaking from Prague. I'm participating the first time, speaking from Prague, you know. Okay. I'm a revolutionary in everything, you know, in my thinking in everything. So I give you respect for your presentation, which is deep and total, but I have quite a different view. Health system, I participated for the first time because I saw the forum is going to be about health. Health system is important. That's, without health, there will be no nation. So very, very important. But I think that like the educational system that you have, if I listen to the presentation of Brother Binka, our health system foundation was from the colonial times, taken over by the Nkrumah time, extended to this time. So basically, like our educational system, it is also from the colonial times to this time. And it quite needs transformation, total transformation. The transformation the health system needs is not exactly what I am hearing, because my view is that our health system, as well as our educational system, must be compatible with our geographical situation, our geographical location, our physiological composition, who we are, our cultural identity, everything. So basically, the health system we are having right now, it's in tune, it's in kind of, as Professor Akosa was speaking, he was referring to England, making references to England. We should be making references to Ghana and to our ancestral way of doing things. How did our ancestors heal themselves? They obviously lived longer than us, don't they? They did. Our ancestors lived longer than us, quite frankly. So for me, I'm saying that the health system needs transformation. I'll be quite brief. It needs transformation. The kind of transformation I'm looking at is the same way I'm looking at the educational sector. We are Africans, we are Black. We cannot use the same medicine that white people, we have a different skin. White people medication is not the same what we need. It's totally different. We are different. Our physiology is totally different. So
Brother
I think our health system needs transformation, but it must go with our cultural identity, our physiology as African people, our geographical location. If that, I have experience of this before myself. For the last 30 years, I don't do Western medicine, even though I live in Europe, because I got sick in Europe one time and all the machines in Europe here didn't cure me. I went to Ghana. For 6 months, I was running around Germany all the time. They couldn't cure me. I went to Ghana 30 years ago. Within 2 weeks, an herbalist cured me. I know, I've made this experience. Please, my situation is that, my position is that the health system needs transformation, but the transformation I'm thinking about is not what I'm hearing. Like the education
please. I think your point is well made, and we're having a series of policy discussions, and I think that we had a number on education. This is our first one on health. There are other dimensions of healthcare that PAG plans to address. But you know, in the interest of time, you've made a contribution. I think others also would need
It's ended. Yes, sir. Thank you.
Thank you so much for joining from Prague.
Yes, please.
We will get in touch with you because we are expanding our tentacles every day. Thank you.
Actually, I came because of Professor Akusa. You know, I saw the name and I said,
okay, no problem. Since you are here, we have captured you, and that's it.
Thank you. That's all. Thank you very much.
We appreciate you being on very much. Thank you so much. And thank you for your contribution.
All right.
Can I, I'm also here.
I have a question.
Linus.
Linus,
Yes.
Dr. Eugene is queuing the questions. Where are we now?
Infinix Note 7.
I've already written a note. I've already written a chapter.
Okay,
I mean, the question.
go ahead.
In case you haven't seen it.
I'll get back to the chat. I went first on the chat and I went to the hands raised on the screen. Now I'll go back after I'm done with that. Please be patient.
Thank you. Thank you very much.
Infinix Note 7. I don't know who you are, but if you are around or you have your hands up, if not, I'll go back to the chat.
Yes. Good afternoon to everyone. Good afternoon to the professors and then everyone on the platform. My name is Stephen Samdodu. I am a principal physician assistant and then also a representative on the Research and Education Committee of the Ghana Physician Assistant Association. Now, listen carefully to all the conversations that went on. I think there is one thing which needs to be addressed. If you look at the health system in Ghana, there is something I call medical imperialism or medical monopoly. A certain cadres of people feel they are untouchable, they are gods. Without them, nothing should happen. One person said that there should be supervision across board. That is true, very, very true. In fact, even specialists are supervised. Medical officers are supervised. Physician assistants should be supervised. Every cadre at your level has a supervision that can be in the scope of. So I feel, and then also with the presentation, it was all going down to the primary health care. Now, 60 to 70% of Ghanaians live in the hinterlands or in the peripheries who are taken care of by the people in the CHIP compounds and the health centers manned by physician assistants. Now, if there is a problem, the first person of point of, so in this case, if the community health nurse is not given a proper training, but rather we think that, oh, people who didn't have good grades should rather go and do community health. First person or the first point of call should be the person to manage the thing so well. Physician assistants as the gatekeepers of primary health care, especially at the sub-districts. And then sometimes you may even find some of them even in teaching hospitals. Don't you think that the Ministry of Health and the Ghana Health Service are not doing something I call generational thinking? The reason is because after 60 years of training of these physician assistants, there is no single career progression for these people. They are left to wander around. Can't we train physician assistants in psychiatry in this and this and this and this and that and put them at areas where at least, imagine Kintampo, Techima Kintampo, Tamale Road. In a year, look at the number of accident cases there. Kintampo Municipal Hospital is there. Can't we train PAs, at least 3 physician assistants in emergency medicine and in trauma and place them there to at least salvage some of these problems? So I feel that monopoly of some certain group of people who feel that medicine belongs to them, is their birthright, should be broken. Policymakers should break that monopoly. It is not helping the system. Healthcare comes from the bottom to the top. It doesn't come from the top down. Cases don't start from Kofanochi to health center. It starts from health center to Kofanochi. So people who are at the peripheries needs to be what? Built, their capacity needs to be built so much. And I'm so much concerned about that. And then also, the second issue is, now, this medium of discussion is very important. Does the resource persons have any idea or have any interest of helping these cadres as physician assistants in career progression, because their impact is going to make a lot? Imagine the number of referral cases from Dunkwa and Ofin was to Konfanochi just because of an obstetric emergency, and most of them end up dying in the ambulances. As I said, I'm part of the research committee, so I have a lot of data on that. If there was one single physician assistant who is a gynecologist I'm not saying that physician assistant gynecologist is going to perform everything, but at least because of the knowledge he has in that area, is he not going to reduce the maternal mortality rate at least on that in that part of the country? So I want to ask if there is anything like that. Has there been any proposal or anything advocacy for PAs or physician assistants to be trained in such specialties within a certain scope, at least to manage first-hand emergencies and complications before, even if it will be referred to a teaching hospital, before they get their complications are really managed? Thank you very much.
Thank you so much.
you.
Thank you.
Can we get one of our presenters to speak to it before we move on to the next question? You're muted, Dr. Fred.
So thank you very much for raising that issue. And I think my first comment is that the other health professionals are not here fighting for themselves. So I'm a bit worried that everything you are saying is about physician assistants. The physician assistants, if you live in Ghana, will do well for themselves if these are the things they discuss and promote. We started the promotion for community health nurses. In fact, we changed their names to community health officers. And today they are called community health officers. They didn't fight through that. We worked together and we developed the proposals for them, looking at what already exists. Today, I have a community health nurse who started as a community health nurse in the PhD program at the University of Health and Allied Sciences. She's done an MPhil and she's doing a PhD. The career is there. As we speak today, there are opportunities for physician assistants to advance their careers. One way to do that is to have
can you mute, please? Everybody mute your phone or your screen if you're not talking, please.
So one way for a physician assistant to move on is to enter the graduate training program. And in fact, today there are scientists who have done biology, zoology, they've done nursing, and some physician assistants are into the graduate program trying to get into medicine. The issue is that you want to be trained in emergency medicine. Emergency medicine, yes, but emergency medicine has been developed for physicians. So you have to go through that route unless you are able to establish your own system that will deal with physician assistants in with physician assistants. The problem we face is that we have a ministry that is led by people who don't understand these issues. So when you take these issues to the minister, he thinks this is politics. No, professionalism is nothing to do with politics. That is one way the politicians can never succeed. You can't break the professionals. You can be the president of Ghana, but you cannot change the doctor. He is a trained doctor. He has to look after the people. And you need to sit down and start looking for how we can improve on this. But that's not been the case. The case in Ghana is that first, physician assistants, anesthesia don't want to supervise by the doctors. So who's going to move you from there? You have to move it yourself. So remember, these are the issues. Learning now is a lifelong learning. We are allowing people to go back and retrain so that when you had a difficult start, you didn't do well, but you can get to the top. Yesterday, I got a WhatsApp from my students who were committee disease control officers, enrolled nurses, committee nurses that came to the University of Health and Allied Sciences, did a top up, did a sandwich program. Today, they are nursing officers. Okay. They are disease control officers. The opportunities are there. Okay. Unless you don't live in Ghana, they are there. Look for it. They are there everywhere.
So, Dr. Kosa, do you have anything to add? Okay, I think we will move on.
Okay, I have some questions on the chat. This is from Brother Linus from Finland. He says, and I read, I have heard numerous cases of medical malpractices, misdiagnosis that has led to tragic deaths in Ghana. Is this also part of the lack of leadership, or is that the medical practice in Ghana Is it that the medical practice in Ghana isn't guided by professional ethics?
So that Dr. Kosa is not here, but let me answer that. Look, medical malpractice happens everywhere. In fact, in the United States of America, if you don't have insurance, you can't practice. The number of people who have to use insurance to protect themselves are quite clear. If medical malpractice happens, so you take it, we're 100 doctors. Today we are 1,000. What do you think will happen? Definitely, some people will make mistakes, and there must be a system to correct that. So hearing that there's medical malpractice alone tells you that the system is there to find those people out. And the supervision is also there. And people have been taken to court and they have been put to jail, actually. There's an obstetrician in Takoradi who went to jail. Okay? So the system is there. The medical malpractice has to be dealt with by patients and doctors. You have to report that there was a problem or people took advantage of you, and then the Medical and Dental Council will investigate that. Yes, there are medical malpractice, and that's not strange.
Okay, thank you for that. Move on.
Next question from Siram, Brother Siram says, is there a Pan-African Association of Medical Doctors? If yes, then vaccines and others can be looked at that level as for Ghana.
Is Dr. Acosta still with us?
Looks like we lost him.
We must have lost him. Then
I have a question.
Just a second. I'm just wondering whether the question that was just asked, if there is an answer, and we can open it up to anybody who also is in the field and has a response to that. If not, okay.
That's fine. We don't have a Pan-African Medical Association. There's none.
Okay.
Yeah.
All right. Thank you. Okay, go ahead.
Brother James, do you have your hand up on the screen? If not, let me
Yes,
give you the opportunity to ask your question.
I have some comments to make. It's my first time of participating in this program, and I want to commend everybody who put it together. You are very great. I'm not a medical doctor. I'm in the field of education, and I've heard from Kofi from Prague the need for restructuring the whole system. That's transforming the whole non-educational, the whole program for just as we needed for education. My field is in education, and I wrote a restructuring colonial education for promoting rural economic development. That is my area, but the same thing applies to the health system. I agree with the presentation regarding the need for having the whole system from below to the top. That means that the need from the ground, the basic needs, the rural areas, health education centers, they are very, very important. And the whole thing is, when you think in terms of restructuring a system, who is in charge? My understanding based on this presentation is that politicians want to be in charge, those who are not qualified. What do we do to bring this transformation? Who should be in charge? Okay, I'm speaking from New York, the US.
Thank you. That's a good point. Who should be in charge? Yes. That is well noted. We'll have to take that as one of the big questions to be answered. Okay, let's move on.
So our system, can I answer that? Our system,
certainly.
Yeah, our system today is completely, the Minister for Health is in charge. You cannot on our own make the changes. There has to, and the Minister for Health has to take advantage of opportunities that come. So for example, post the pandemic that we have now, everybody's going to do some reforms. So this will be a good chance for them to do the reforms. And there have been many articles in our local papers talking about the reform. Whether it will happen or not, I don't think I know that answer. And let me also take advantage to tell you about the development from bottom upwards and the systems that we are talking about. In fact, the primary healthcare system that was adopted in Alma-Ata in Russia in 1979 was a product from Ghana. Ghana developed the primary healthcare and has the documents from 1978. It was those documents that were sent to Alma-Ata in Russia. So if you want to talk about an indigenous way of providing care, that is one indigenous way of providing care that we must deploy and implement, modify, and take it to the end. We have always tried to avoid it. But primary healthcare, you can check from the records. In Ghana launched its primary healthcare in 1978. The Alma-Ata conference by WHO was in 1979 in Alma-Ata in Russia. Thank you.
Have we considered the need for holistic health education centers? Holistic health education centers, that includes everything. That is naturopathic doctors, not just MDs, naturopathic doctors. Then our own system, traditional system, water, and everything integrated. That will bring health to rural areas.
Thank you. Let me comment here. I think Professor Olsen said that there will be an opportunity. This is the beginning of this health series forum or conferences that will be holding. So that will probably come later on in another segment. But yes, I think all those are considered. Thank you, Brother James. I would now go to Dr. Oklu. And please try to be brief because this is a record attendance. We have had 41 attendees today, unprecedented.
Thank you, Professor Sola. I'm just going to make a very brief comment. Two key points. One, the food sector in Ghana sometimes creates health problems. We need to look at that. I can give a clear example about myself. 2015, I went to Ghana to bury my dad. I nearly ended up going to the same coffin with him. Why? I just bought 2 eggs on the mortuary road, ate, and that was it. So the food sector and the stores that everybody wake up in the middle of the night to set up in Accra or everywhere should be questioned, and there must be a good guidance and a good direction. One. The next one is about this continuous appointment by politicians, political parties, somebody from some funny secondary school somewhere because he belongs to a party, wake up and is appointed health minister. You must have a system to challenge that. So when colleagues are calling for a whole transformation of the health system, it's something we need to take seriously. Thank you.
Thank you very much. Yeah.
Let me see. We don't have any hands up here now.
We're nearing the top of the hour, and so we should be coming close to the end of the session, but go ahead. I see there is a hand up.
Oh, Professor Akosa is back. Thank you.
Okay. Who is G Thing Q? Is your hand up?
Hello?
Yes.
Yes, I'm Dr. Amana Kise. I am an older physician. And I am impressed with the presentation made by both of our presenters. I think their solutions are the solutions we need in Ghana. I left Ghana a long time ago when the police were giving BMWs as chase cars and we didn't have chloroquine in the hospitals to treat malaria. I think what they're saying is what we need to do. I think what we need to do is to actually make a group so we can force the politicians to do what we need done. We do a lot of things in Ghana that are not what needs to be done. I heard a physician assistant talk about being in control of their physicians. They call it a physician assistant for a reason. I used to teach for the University of Colorado Health Sciences Center. That's where they started the physician assistant program in the world. And when you're in Colorado, a physician assistant works under a physician. And in Ghana, we know how you become a physician assistant. And so we shouldn't change those things just to make things suit the people who want to be suited. We should do things that will work for the country. What I would suggest is that we actually make the group force our governments to do what is good for us. And I think what they suggested is an excellent start. Thank you.
Thank you very much.
And there's one last comment on the chat. I think Professor Akosa already answered that, but I'll read it for the benefit of the group. That what will it take for change to happen? Professor Akosa has been consistent in calling for a unitary health system in Ghana for years now, but there is no such reform happening. In my view, progressive groups such as PAG need to help in prioritizing health reform and in building the movement for that to happen. Thank you, Brother John.
Can I just add a word? I had to go off because even though they say there's no doomsaw in Ghana, they just put off my lights. Only to realize there was no fuel in my generator, so I had to send for fuel. So now I'm back. now
Glad to have you back.
Thank you. I think it is important that, you know, that there must be, I know Fred called for a reform, but I will call for a health forum, a national health dialogue. See, one of the things that I didn't have time to talk about is the other players within the health system. You know, pastors, people who believe that they are God ordained to heal people, and unfortunately are destroying people. Superstition is so rife in Ghana that the hospital is the last place everybody goes to, even though it should be the first place people go to. You know, they will do all sorts of things. Herbalists will do whatever. You know, our traditional health system may be good, but again, we should all understand that, you know, there's development in this world, and we cannot go back to what ancestors used to do. That is why there's a Center for Research into Plant Medicine. If you think you have got something, take it there. They would look at it. They would assist you to create a better system. But here we are just there, and people are just messing up Ghanaians. By the time they get to you, they are almost always virtually on a deathbed, and they just come and die in the hospital just so that it can be noted in the obituary that they died in the hospital. But they would have been at a prayer camp, a faith healer, whoever, Kominini, no health professional participates in all those things, you know, and yet nobody's talking about it. And that's why I say there should be a national health dialogue. We need to talk. We need to talk because health is so important. The lack of it, our nation will perish.
Thank you, Dr. Kosa. Do we have any, I see there's something else in the chat.
That is from Brother Linus, and the information has been forwarded to our the moderator, and the moderator will do well to send it to you later, Brother Linus, if you would be patient. Thank you. Now I hand it back to the moderator.
Yes, we do have the slides, and we will be forwarding it to those who are interested. So you can send send an email. Is
Go for it.
Dr. Roberts here? Perhaps you can give the email, and we will put the email in the chat, and we will forward the slides to those who have requested it. Thank you.
Okay.
All right.
I don't have any.
Just want to ask.
One other. All right. I think
there's a
this
hand
will
up.
be the
iPhone.
last comment or question, and then we will be wrapping up. Okay.
iPhone.
When is the next forum, next discussion coming on?
That will be determined in a few weeks. We will definitely be communicating that. The next one is on agriculture, but we will be having additional sessions on health, and we will be communicating that as we go along.
I want to congratulate all of you who organized it. This is fantastic. It really
Thank you so much.
Development of our nation. Sure.
We have Brother Bodu.
Oh, me, rather, I've kept quiet today, so
somebody has an iPhone. I don't know if it's you, but somebody.
Yeah, iPhone is good. I just wanted to ask Dr. Akusa's opinion about how do we increase, and both of them, though, Fred Denker and Dr. Akusa, how do we increase the nursing schools in the country? I mean, there are few, obviously, and they are turning our nurses. I don't know the specialties of these nurses. Are they studying only nursing or other auxiliaries of nursing education? Because these are centers that are open. They say they are under what? One person. And I don't know if this person has all the skills. So do they need assistance themselves, or how do we increase that? I just want a little explanation on that, because they seem to be very good concept, but are they effective, for one person to just handle that sector, that section alone, or they need assistance? So how do we increase the nursing education and the nursing personnel to make it more effective? Any one of them can answer,
Thank you.
Let me say that it's fair to say that in Ghana, we have a lot of nursing schools. There are a lot of private nursing schools. Now, the first thing is to make sure that they are all competent and are able to produce the nurses that we want. One of the things that we don't do well, and I know that there is the establishment of the Postgraduate College of Nursing, it's for them, apart from critical care and ophthalmic nursing, they do not do the other specialties like respiratory nursing, dermatological nursing, and all that. These were things that when I was Director General, we mooted the idea. We almost started it. We had the first batch of students who were going to University of Glamorgan then. And then, of course, I left the service because I just couldn't, whatever you wanted done, the minister had his way. And therefore, there was no point in continuing as Director General, and I left. But the situation is that as far as the nurses are concerned, if we begin to have nursing specialties, then you can virtually get the complementarity of a good physician, a good specialist nurse doing the work. If you hear a kidney, a renal nurse speak, sometimes you just have to pause and wonder whether the person who is speaking is really a nurse or is a physician. Some of them are so good that I think those are the calibers that we need to be able to, help the system.
Thank you.
But there are enough nursing schools. There are enough nursing schools.
Okay, thank you. But the education is just structured to nursing, but not too much of the auxiliaries like X-ray technicians or even EKG technicians or that.
They are not categorized as nurses. They are they are called professions allied to medicine.
Okay.
Yeah, and they have their institution, even though again they are not producing enough, but they are producing EKG nurses, radiographers, dietitians, dietetics. All those categories are being produced, including biomedical engineers. So the system is there, but like most things, you produce 50 odd, 100 odd in a year when we need to be producing significant numbers.
Okay, thank you, sir.
Yeah.
Thank
Well,
you.
with the universities also now offering these programs, we are beginning to have a lot more people in those allied health sciences. And now there's the Allied Health Sciences Council also that provides them with the professional certification. And now they can get into the system. You know, both the ministry and the training institutions have to work together so that when these people come out of the university, they don't find that they cannot be employed. That's been one of the biggest headaches that we have, but we are making progress.
Okay, thank you. Before we move on, I had spoken with Susan Amankwa. I'm wondering if she is on, because I would really would like to hear your perspective as well. I know you have been very active and critical to the field as well. Would she be on here today?
Yes, I am on. I've been listening.
Would you have any comment or anything to add to the discussion so far?
Well, I think that the discussion has been interesting, and definitely the two professors have, tackled it very well. There ought to be the holistic looking at the strengthening, our health system, and from all aspects. There must be the political will to actually do it. There is no gainsaying that sometimes politicians want to see certain tangible things, and so that they can use those tangible things as a bragging point and say, oh, we have built this, we have built that, we have maybe 50 nurses, and we have brought them to 200 and things like that. But those are not just the things that build up a health system. There are, there are a lot of intangible things that build up a health system, and that needs to be looked at. So, in wanting to strengthen our health system, I think we need to look at all aspects of, of it, both the tangible things and the intangible things. And the politicians need to realize that sometimes those intangible things are very important, and money has to be, put to it so that we can move forward. But basically, that is the thing, and I think the professors have tackled it well. I, also experience a bit of doomsaw, or these days we call it interrupted power. It's not called doomsaw. So I missed some part. I missed some part of it, but I wanted also to look at it in terms of research and development, and I think that it may have been it may have been talked about, but I'm a researcher, and I know how important it is for when we're talking about evidence-based strengthening. What are the things that research needs to do so that all the things that we do in terms of strengthening our health system is evidence-based, small surveys here, some epidemiological surveys here, etc., etc., etc. Those things that we need to do. I know somebody talked about said something about, I heard the Pan-African and then vaccinology, put somewhere in that sentence. And I'm an advocate for us to go out there and do the research that will make us say that this vaccine is good for us, that vaccine is not good for us, or this drug is good for us, or that drug is not good for us. Yeah, yes, there is that lack of funds from our government to fund research.
So just imagine.
Please, you're not speaking, please.
Yes, and that's why we are saying that. Also coming.
Hello. Can we mute? Okay. Sorry, Susan, go ahead, please.
Okay, so I'm saying that our governments have not really funded research, the kind of research that boosts our public health strengthening or system strengthening. They have not put the kind of money that needs to be put there and get the results. I mean, I look at it and there's always
and we are telling you that
hello. Pakwesi. Hey, can you please mute?
I come to office and I tell you I'm a doctor.
Hello.
And I've come to
and this Brother Kofi, can you mute from behind? Thank you.
I mean, there's always wasted opportunities, I was discussing with, I think, Dr. Sakara the other day that we have this testing of COVID at the airport. The persons, the people there were trained by Noguchi research assistants. In fact, in the beginning, the place was manned by Noguchi research assistants. Why did the government not say that, look, we will still charge 150, but we will let Noguchi do it, and that money be put into a fund for Noguchi to do research and come out with whatever. And why this COVID is skipping the African people, or is it just God smiling on us, or is it something that we are doing? As Prof said, why that money that company made, why could it not have come to a government institution that can be accountable and bring out research? That shows why we as Africans have been smiled upon in this COVID pandemic, but we chose to give it to private people. We don't know where that money is going, what is going to benefit us as Ghanaians. And so as much as there's the technical aspect of public health strengthening, that political will to do the right things is really, 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 really important.
Thank you, Susan. We really appreciate your input, and I'm glad you were able to speak before we ended everything. I see that there are a number of people still wanting to ask questions or make comments, but we are past the top of the hour. We usually go until 11. Certainly we can, some that may want to stay on and discuss may still do that, but we will have to at least wrap up and then see who else is on. So at this time, I want to thank everybody who has been part of this. All those who have contributed, we want to thank our presenters, and I will pass it back to Dr. Olson. Are you here to end the program? Is Dr. Olson still here?
Nyan or Brother Kofi, Robert will be around, or Brother Bodu.
Brother Yen.
Yeah, I'm around, yeah.
Okay.
Yeah. I mean, on behalf of Progressive Alliance of Ghana, I wish to thank you all for attending. Somebody did say that this is a record meeting. Yes, it definitely is a record meeting because health is extremely important. We have the same problem. I'm speaking from Balgatanga. The issues that Prof. Akosa raised are the problems that we are going through. The issues that Fred raised, the two professors, all of them raised, are really important for us. And we hope to continue this discussion, and then we hope that you can all attend the sessions. But just a little bit, somebody will ask, why are we organizing these things? We, like I said, we are from the Progressive Alliance of Ghana, and we are made up of small groups or progressive organizations and individuals who want to bring about change in Ghana. Currently, we have a provisional license to operate as a political party, and we wish to come out as a political party in the future. And you ask, there are many parties in Ghana, over 20 parties in Ghana, why we want to become a political party in Ghana. We want to become a political party because we believe that the real issues that confront the country, the fact that the country is controlled by foreign companies, you know, that 87% of our oil is taken out, that 95% of our mineral resources are taken out, is the root cause of the problem that we face in this country. So we hope that you can join us. Look at the chats area if you are interested in joining us in this journey. It is not very easy. Like I say, I'm in Bolga here, and sometimes we go to the villages to talk to people, and when you finish talking, they say, give us money. This is not easy. You can see how the problems we are going to, what the two main political parties have done to us and the other smaller parties. It's all about money. But we keep on telling them that, listen, we want to organize, we want to return to Nkrumah. In actual fact, our motto is to return to Nkrumah. The idea, not that Nkrumah was so, yeah, he was a very handsome man, but we don't want to return to him because of his beauty, but because we believe in his ideas, the ideas of import, export substitution, the ideas of support in the health sector and others. So we hope that this is not only put your email address, contact us. We need support from everybody, your material support, financial support, whatever support that your ideas, like the two professors have given to us, is worth more than money. We hope that, and we thank you all for coming in, and we hope that you will be part and parcel of PAG. It is there, it's a movement. Most of us, the leadership, are interim. And particularly to you, the youth, the young people who are here, this movement, this mass organization we are building is for you. Some of us probably don't have many years to live. I hope to live to see a real transformation. We've talked about transformation in health, transformation in education and others. One complete transformation. And it is you, the young people, who can bring about transformation. So we hope that you can engage with the PAG and support us to realize our dreams. Thank you very much once more.
Do we have a website? A website?
Yes, we do.
Please forward it to all of us.
Please go ahead and give the website.
At the bottom of the flyer, you would find it if you have the flyer. If not, we would email it to you, Brother James, if you have your email.
Okay, thank you.
Brother Kofi, do you have it?
want to
ProAllianceGH.org.
okay, come up with
ProAllianceGH.org.
PRO Alliance ALLIANCE
Yes.
.org.
Yeah, and then but basically there've been quite a number of people here who have attended. I don't know whether I've seen Professor Aki. Sorry, is he the real professor that we know of? We are pleasantly surprised if you are the one to see you around, or is that Akilapa Sawyer, Professor?
Yes, indeed it is. It depends how you define professor, but I am.
Yeah. We are so happy to see you there.
Thank you very much. I've learned a lot.
Yeah, so nice. And how is I hope Accra is okay.
Well, Accra is okay. Can I just make one short comment?
Go ahead, please.
That is to emphasize the takeaway point, which I gather from this. That is the importance of beginning from the base. What I've heard today has been so persuasive that it brings up the question of agency. How do we get this idea to a much wider audience so we can get around the politicians and their focus? We need to mobilize on a broader scale, not simply ideologically, because what I've heard today makes so much sense that if it were put to a wider circle, I think we can generate enough force and support to compel our politicians to listen. So again, an idea I want to throw out. Thank you very much indeed.
Thank you very much. Yeah, and then if I haven't called any of these professors who have attended, thank you all for attending. It's really, really nice to see people like Aki and all those people here.
We appreciate you all. Thank you. I think we have come to the end of today, and we look forward to seeing you all on our next session. We'll be contacting you. Thank you.
Congratulations, you did excellently.
Yeah, and as Phyllis said, if people want to stay briefly for further discussion and introduce themselves, they can stay, If you haven't introduced yourself, if you want to stay, you can go off now. The meeting is finished. But if you want to have a short chat, introduce
well, I just want to ask Ian why he's not wearing his Western Samoa shirt today, because that looks very fine on the screen.
Which shirt?
The Western Samoa shirt you've been wearing.
Smoke?
No, the Samoa shirt, the one with the colored, beautiful color one. Because Nick doesn't show his face on the screen because I don't know he's afraid of anything. So, but if you come with that Samoa shirt, it makes the whole generation look a bit brighter. That's what I'm talking about.
Oh, okay. Next time I'll wear it. Yeah.
Please do.
Nick doesn't do what?
Nick doesn't show his face on the screen. We don't see Nick's face on the screen.
Nicholas, are you there? Perhaps you can.
So
he has never shown his face.
No, his face was shown. He was even leaning at the back.
No, he's not. I haven't seen it anyway.
Oh, I think he's still there, so he has an opportunity to do that.
Well, I'm grateful to all of you. Thank you very much. Bye-bye.
Thank you.
I have a special appeal. I know usually we don't have that many females or women among, and we have a few of them. Could we see their faces and introduce yourself, please?
Is Marie Marceline? I don't want to put anyone on the spot, but I've already introduced myself. So I see Susan spoke, but she's off now.
Susan spoke.
Oh, she
most
is.
of the mics, most of the mics are muted, so I don't know. But I have to leave you guys.
Even if they're muted, they can hear us. Susan, are you still there? Well, she's Marie. Are you there?
Yes.
Oh,
yes,
okay.
I'm here.
Are you able to show your face and tell us a little bit where you're from or where you're coming?
Okay,
If
so
not,
I'm
just
showing
say
my
where
face.
you are.
So I hope you can see. I'm showing my face now.
Okay, hello, Susan. Yes. Okay.
I didn't touch the rest of your question.
Susan,
There's a bit
are
of
you in
interference.
Ghana? You are in Ghana,
Yes,
right?
I'm in Ghana. Yes,
Okay,
I'm in
great.
Ghana.
And Marie, where are you?
I am in Ottawa.
Oh, you're in Ottawa. Oh my. Oh, you're here with me.
Yes, it's Marie Carmel Marcelin.
Ah, okay. Hello. Nice to see you. We'll have to get in touch sometime.
Yes.
All right.
I'm also a pharmacist, and then I'm an owner of a Coco Carib.
Okay.
That's
Yes,
it
all
anymore.
right.
I am on that business.
Yes, we are on WhatsApp, aren't we? Now I know. I see your face now. Great. Anybody else?
Anybody wants to introduce himself or herself?
So anyone?
The quality of the sound is being affected, and that's one of the reasons why I tend to switch off my video. Yeah, for most people who don't have broadband facility, excessive use of the video affects the quality of the reception.
Grammar is important, but if you want,
If
Right,
anybody
bye, everybody.
has any
Everyone
comments
have a
on
blessed
anything,
weekend.
otherwise we will sign off.
Okay.
Okay. So Kofi, sign us off. I think people have finished talking. And then we hope to have you all at the next meet session.
Okay. Good day and meet next time.